Good morning to everybody. I introduce myself, Guido Gasparri from the University of Fiore in Italy. I am very, very honored to be here with you, and I present the next speaker, Professor Stack. AHNS BAETS Joint Revision Parathyroid Guidelines.
Thank you very much. I appreciate the organizers of this program for the ability to present some of the work I've been involved with as a collaboration between the American Head and Neck Society and the British Association of Endocrine and Thyroid Surgeons, and we'll be discussing some guidelines that were generated on re-operative parathyroid surgery. I think you'll find that a lot of what we talk about now and what Dr. Thompson just finished talking about fit together nicely. Dr. Thompson was involved in our writing group. These are my disclosures, and this is a picture of the masthead from the article which appeared in Head and Neck last summer electronically, and I think later in the fall in print. So Dr. Thompson already mentioned Dr. Dopman, but I think in a reoperative parathyroid talk, it's very apropos to mention John Dopman. It's interesting because he made this quote, but he had no skin in the game as far as being a surgeon or a non-surgeon. Well, he was a non-surgeon. He was an interventional radiologist at the National Institutes of Health. But since he was involved in a lot of the interventional radiologic diagnosis of localization of parathyroids, he's a person that had a unique perspective, and he said the greatest challenge in parathyroid localization is to localize a good parathyroid surgeon. So that certainly wasn't a self-serving comment for himself. So just very basic place that we all start in the same place. We have persistent hyperparathyroidism, which would be the persistence of biochemical abnormality from immediate postoperative period up to 6 months. So this would be the initially failed surgery, and many of us who are in busy practices will get these patients referred in to us. And then, of course, this is distinct from a person with recurrent hyperparathyroidism, where they may have initially had a successful parathyroidectomy. Per Dr. Thompson's remarks, at 6 months, maybe a year, or even 2 years, they had normal laboratories, but then subsequently then developed an abnormality. And these are people that probably had multi-gland process going on all along that had not been recognized. This is a table that we lifted from the British census of endocrine surgeons, and this is to highlight the stakes at play with primary parathyroid surgery. Obviously, it's much more straightforward and there are fewer complications. And so this should be one of the reasons, an onus, you could say, for doing the surgery right, doing it successfully the first time, so that we don't put ourselves or our patients in that reoperative situation where the stakes are a lot higher. So we're going to go through this piece by piece, but I just wanted to give this slide as a broad overview of how the reoperative guidelines were broken apart. We basically address reoperative parathyroid surgery in 3 domains: a preoperative evaluation domain, a surgical management domain, and then ultimately sort of as a last resort medical management domain for people that would not be considered operative candidates. So as far as our first recommendations were concerned, the first step in the evaluation of a patient with hyperparathyroidism, possibly requiring a reoperative procedure, must include a complete biochemical confirmation of primary hyperparathyroidism with hypercalcemia, relative or absolute hyperparathyroidemia. That tips our hats to the possibility of a borderline case, and preferably hypercalciuria before operation. So basically, in some sense, reoperative parathyroid surgery is like doing the first surgery. We have to go through that same rigorous evaluation process, have a differential diagnosis, exclude plausible things that can be easily excluded, and then confirm that, in fact, we have in front of us a patient that indeed has persistent hyperparathyroidism. The diagnosis of hyperparathyroidism must be secured through exclusion of non-parathyroid causes. So certainly we don't want to have a repeat operation on someone with FHH. And then, of course, there's a very long list of causes of hypercalcemia, too exhaustive to go through in this particular setting, but things like granulomatous disease and other diseases need to be excluded. Many of us in this room have seen patients referred to us for failed parathyroid surgery when in fact had a non-surgical reason for their apparent failure on preoperative laboratories. Something that's very valuable is really reviewing the records. Now, this can be tedious and this can take a lot of time. And for someone like me who has a little ADD, this sometimes is most challenging. And I find that by taking, and I'll show you a picture of this later, by taking the data available to me, and in the United States now with electronic medical records and the joining and cross-talking of electronic medical records, this has theoretically become easier, but it's still a mundane process. You can take all of this information and pictorially very easily present that to your patient and to yourself as an overview as to what happened in the previous surgery and what is likely the location of the residual hyperfunctional parathyroid. So here's this little 2x2 table that I like to do. I find this helpful in my teaching with the residents to just sort of be disciplined and go through step by step what has been done with the surgery, the details if available, and many times, to Dr. Thompson's point, a lot of the operative reports that we review aren't that detailed, and so it involves some guesswork as we go through the review process. But certainly having a detailed operative report during the first surgery is very helpful to the surgeon that may be involved in doing a revision surgery. It becomes sort of like a forensic process in order to determine where in the neck, in a eutopic position, the failure would most likely be represented. Of course, there's always the possibility of a missed ectopic, and that's sort of a different discussion. Recommendation number 3, assessment of the patient's current health status and previous surgical complications, if any, must be handled before planning for reoperative surgery. Now, most patients that present for reoperative parathyroid surgery, in my experience, have not had a significant interim decline in their overall status. But what we specifically were thinking in these guidelines is, what if the patient had been operated on by a low-volume operator and developed a vocal cord paresis? It becomes very important to make a determination if that's something on the table during the reoperative encounter, because all of a sudden, if you have a person presenting with paralyzed ipsilateral cord and you're going to be doing contralateral work in order to cure the hyperparathyroidism, in theory, tracheotomy would be on the table, and issues of intraoperative nerve monitoring, and your comfort level of doing that, and experience doing that, et cetera, et cetera. So I don't need to belabor that point, but more information is most often very helpful in this regard. So this transitions into our recommendation that the larynx is actually evaluated in these patients before a reoperative parathyroid surgery. Now, all of us have different ways of practicing. Some of us, because of our training, are more comfortable with scopes, some less so. We do not mandate in these guidelines a specific test that needs to be done, but just that an appreciation of laryngeal function needs to be obtained preoperatively. Now, being an otolaryngologist, and I fully recognize that, laryngoscopy is in my wheelhouse, and that's something that we use frequently, and it's something that's very well tolerated by the patients and fairly cost effective. So now we're still in the preoperative domain, so we haven't even taken our patient to surgery yet, but we need to get some reoperative imaging. One thing that we recommend in this paper is preoperative imaging of reoperative parathyroid surgical patients is mandatory. Although you may end up doing a bilateral exploration, you really need to have the advantage of preoperative imaging to guide you to that. That may actually be helpful because it may avoid excessive exploration in an area that doesn't demonstrate the likely residual parathyroid, and that may reduce the morbidity of doing such a procedure. Recommendation 5B, using imaging modality that is readily available, most reliable, and cost-effective in a given health system is recommended. This will vary upon location. So we try to have in these guidelines flexibility that not everybody has 11-choline. Not everybody has world-class ultrasonography. Maybe, as in my institution, we prefer 4D CT, but some people may not have adopted that. So we don't prescribe this imaging versus any other particular imaging. As a personal bias, I'm a big fan of 4D CT, and we've used that as our second imaging test on all of our parathyroid patients exclusively since 2013 because of some early successes we had with it in 2011 and 2012. Recommendation 6, reoperative parathyroid surgery should be performed in the setting of an identified target gland on preoperative imaging studies. In other words, we don't make an argument that if you have a person who is biochemically evident to have a recurrent or persistent hyperparathyroidism and they have negative imaging, that these are people that you should rush into exploratory surgery at that point, unguided bilateral exploratory surgery. Now, there may be certain cases where that might be indicated. However, we feel that in order to optimize the outcome of patients that are undergoing reoperative surgery, it's exceedingly helpful in the reoperative setting to have an identified target or targets that are the focus of the reoperative surgery. So this is just a nod to that in a reoperative case, and this came from a paper where we had 21 patients that presented to us with non-localizable disease, and this was right as we transitioned to using routine 4D CT. And we were able to identify on 4D CT 20 of the 21 cases, and those were all successfully treated by surgery. So now we are going to transition into some more operative details. We all know that parathyroid surgeries can be challenging, and they should really be undertaken by experienced surgeons. Experience really does matter when you are dealing with a potentially highly scarred and altered anatomy that you might see in a reoperative setting. In the 8th recommendation, parathyroid glands should be approached through non-dissected planes, avoiding, when possible, most heavily scarred regions. So Dr. Thompson touched on this in his talk with using the lateral approach. I'm a big fan of the lateral approach. And if you have a reoperative patient that has a well-defined target and you have intraoperative PTH and you can approach that nicely through a lateral approach, that would be a great case for doing that and avoiding the heavily scarred surgical field and the potential for vocal cord paresis or hypoparathyroidism. So surgical approaches have been described in the reoperative setting many times. Dr. Thompson has described them. Dr. Udelsman, Dr. Moley have all written on this, and their references are up there. But basically the concept is try to approach the area for the majority of the surgery through a plane or a set of planes that haven't been previously dissected. So if someone comes in that's had a lot of central work, you might want to consider lateral. If they've been worked on low, you may want to approach from high, or vice versa. That's the basic concept. Obviously, there are more details when you get to a patient on patient level. So the next couple of slides show some cartoons from Dr. Thompson's work. Here, the lateral approach is depicted for a patient who's had undergone a standard midline approach, and you can see the lateral approach. And most of us that have had experience with this This can get rid of the first 5 to 10 minutes of frustration that you might have in the case. And then as you're getting down to the adenoma, or perhaps if the previous surgeon wasn't even close to that adenoma, maybe the whole case will be a breeze. But at least you're not getting frustrated from the very beginning of the case, and you're still fresh, and your mind is fresh, and your skills are fresh when you're getting close to the adenoma. Here again from Dr. Thompson's work, if preoperative localization indicates an ectopic or what I would call a non-eutopic gland in in an area where you would suspect but slightly out of place, you can approach it superiorly. And for those in the carotid sheath, great care needs to be taken not to injure the carotid sheath structures. One approach that I have found helps me more than any other approach in the preoperative setting, and this is based on the cadre of patients that I've done revisions on, is this concept here where you identify inferiorly the thyrothymic ligament, and you're able to, by upward retraction of the thyroid lobe and the thyrothymic ligament, you're able to find a slightly inferiorly placed parathyroid adenoma, and you can actually bring that up from a non-dissected area from the previous surgery, and it can be quite effective. And this is a nice picture that sort of shows common places to see abnormally placed glands in a reoperative setting. So these should always be places in the back of the mind during the reoperation where, well, I'm not finding what I'm expecting, and these are places that should be routinely examined. So in the 9th recommendation, intraoperative adjuncts such as nerve monitoring PTH assay should be deployed if available. Some people have used radio tracers. Radio tracers can be helpful when appropriately used. Unfortunately, my appreciation of this has been many people try to use radio tracers like a divining rod in a wound, and that's not how they were designed to be used. Intraoperative ultrasound can also be helpful, and all of these deployment of these technologies are dependent upon the operator's experience with such. So here's just a picture of some of the various toys that people use during revision cases. They all have their merits. Again, hearkening back to our recommendation about imaging, not all centers, not all systems have this available and support this. These are basically a menu of things that might be pursued if you get active in revising parathyroid patients. Recommendation 10, during reoperative parathyroid surgery, when postoperative hypoparathyroidism is a concern, I mean, how many times have people been sent in to any one of us that have had their primary surgery and their path report shows 3 parathyroids? I mean, this should obviously be very present on one's mind. We need to be prepared for the possibility of primary autotransplantation, perhaps cryopreservation if that facility is available in your locale. And there should be a low threshold for doing preservation if you're concerned that you're doing a revision surgery on an adenoma that happens to represent the last remaining parathyroid tissue of that patient. Finally, as we wrap up, this is the recommendation 11, which is nutritional and pharmacologic optimization should be performed in patients refusing to or who are not candidates for reoperative parathyroid surgery. And this is mainly in the medical domain. I just say this briefly because I am a surgeon, not because I spend a lot of time in this area. I refer this to my partner endocrinologist who handles all this, but there are options available if people are not surgical candidates or refuse revision surgery. So just to summarize, just a few bullets here. The practices are essentially the same for primary and revision surgery as far as the thought process and many of the techniques that are available for the surgery, although some may be more commonly used on primary surgery versus revision surgery. The definition of the disease, hypercalcemia with hyperparathyroidism and hypercalciuria. These are our touchstones for evaluating people for revision parathyroid surgery. It's so important, and in the interest of time, we weren't even able to touch on anatomy and embryology, but this is one of the things that comes along with being an experienced surgeon, that this has already been put into your DNA over time. Concordant preoperative imaging, office ultrasound is very important. I didn't touch on that much. In our practice, office ultrasound, 4D CT, when they're concordant, that's our Rosetta Stone for this situation. Diagnosis and surgical planning for concurrent thyroid and parathyroid disease is very important. Always remember there's a risk because of scar to injure the recurrent nerve, to create a situation of hypoparathyroidism, which is worse than hyperparathyroidism in my estimation, injure the trachea, injure the esophagus. And finally, it's important to carefully review what's been done previously, both from the operative report or the path report. And it's also important to identify where the error in the first surgery may have occurred so as to ameliorate that during the revision surgery. Thank you very much for your time and attention.